Okay, right. Give me a second, guys. Y'all can hear me clearly? All good? Thumbs up. Yeah. Okay. Excellent. Right. So we have some new faces. Right. So some of y'all might have met me before, right? I'm Prashan, for those of y'all who don't know me. Yeah. So guys, just a small introduction, right? I'm Prashan, founder of the Med Commute. So we've been doing this since about 2019, right? We started off with a program called Medicine 101, and we continued that for a couple of years, and then we had some exams and some internships to do, and then now we're back with the Med Commute, right? So the goal is for you all to get concepts from the basics all the way up to the final MBBS level with relation to each topic. So if we take stroke, because you all don't learn this way in the universities, right? They don't have time to teach you all in this method in universities, right? So what they often do is you all learn the anatomy in the first year, physiology, pathology in the second, third years, and then final clinical medicine in the last year, right? Yeah, so so you all learn some basic stuff in the initial years, and then by the final years, you all have forgotten all this. So what we do is we take specific topics. So last week we had a lecture on ischemic heart disease. So we start with the basic, right? The anatomy of the coronary vasculature, all of that. And then we go to the advanced stuff of the same topic, and we correlate that basic to the final medical subject, right? Okay, so just to see some faces, guys, please turn your cameras on. So who's here? Let me just check. Okay, Tarinder is here. Hi, Tarinder, after a long time. Who else is here? Netmini, you've come to classes before? I remember your name. Yes? Yeah, okay, good. Right. Who else is here? Muhammad Taimur, where are you joining us from? Where from? Unmute and talk.
From Pakistan.
Pakistan. Excellent. Your university is also in Pakistan, or you're somewhere else?
No, I'm from China.
China. Which university?
Capital Medical University.
Okay, excellent. Imesh Disanayaka, where are you from? Which university?
Dalian Medical University, China.
Dalian. Which year?
Fifth year.
Fifth year. Excellent. Okay, so Shabib is here. Hi. Manar is here. Good. So y'all came last week. Also good. Dilmi Thilakaratna. Which university? Sorry? China. China. Dalian. Okay. Excellent. Okay, guys. Okay. So just a few things, right? Keep your mics muted except for when I ask questions. Okay. And when I ask questions, I want you all to interact with me as much as possible, right? Students who have come to my classes before, they know. What I want you all to do is, it doesn't matter if you're first year today, right? If you're in the final year, it doesn't matter to me, right? If I ask a question, try to come up with some sort of hypothesis, right? I don't expect you all to know every single detail, right? Even if you all don't know the answer, try to guess. Okay, this might be this, right? And just talk. Okay, just keep interacting with me. One thing, it helps me as well. And it's good for you all also, okay, to get the practice, right? And the other thing, guys, if there is any issue, right, signal related, connection related issues, Sharud is here as the co-host. Just drop her a message, or drop any, you guys can drop a message to any of the WhatsApp admins except for me. Don't drop a message to me. I won't be looking at my phone. Right. So then let's get started, right? Okay. Stroke, right? Strokes. When you all hear the term strokes, what comes to your mind, guys? Anything at all about strokes, right? Just tell me anything about strokes that comes to your mind. Doesn't matter what, anything. Guys, come on. Unmute your talk. When I give you all the chance, you all have to talk, Okay, come on. Just say something. Anything you all know about strokes. Did I point out and ask? Tarinder, let's go. Tell me something about stroke.
Brain infarct.
Excellent. Brain infarct, right? 2 words, right? Very simple, right? Good. So guys, now if you all read the definition, right? I've given you all the note and I've put the pictures there so you all can follow along, right? When we say stroke, right? What does your note say? A neurological deficit attributed to an acute focal injury of the central nervous system, right? By a vascular cause. So the important thing here is, guys, first thing, a neurological deficit. What is this neurological deficit? When the patient comes to you, they are going to come with some sort of manifestations, right? Guys, just keep your cameras on because I've informed the co-host as well, right? Because there were some issues. Just keep your cameras on, okay? Right? So that we can interact and, have the class nice, right? Okay. So a neurological deficit. So the patient is going to come to you with some sort of weakness, some sort of problem with muscle movements or sensory loss or something, right? And due to an acute is the important word here, guys. The characteristic feature of strokes is that it's acute onset, right? acute focal injury of the central nervous system. Now, what the central nervous system is, we'll talk about, right? And the important thing, by a vascular cause, right? Including infarction and hemorrhage, we'll talk about the differences. What does this basically mean, guys? Part of the brain does not have sufficient blood flow, right? Everyone agrees? No, not enough blood flow to some part of the brain. So the patient is going to come to you with some manifestation. So once we get stroke out of the way, there's another important term for us to understand: transient ischemic attacks. Now, what is this transient ischemic attack, guys? This one is basically like a stroke, right? Basically like a stroke. Again, we have neurological deficits, right? Again, due to a vascular problem. But the difference is, in strokes, we have cell death, right? Cell death, tissue cell death in the brain. Whereas in transient ischemic attacks, it's transient, it's temporary. There is no cell death, right? Now, previous definitions, if you all have studied some old guidelines, they might have mentioned, if ischemia is lasting more than 24 hours, we take it as stroke. Less than 24 hours, we take it as transient ischemic attacks. That's not the case anymore, okay? We don't use that definition anymore, because what we've seen is even less than 24 hours, a person can suffer from cell death. Cell death can occur, right, in the brain, right? So we don't use that definition anymore, right? Now, that is out of the way. Then the other thing is, guys, hemorrhagic strokes. Now, we are not going to focus a lot on hemorrhagic strokes, but what I want you all to know is, let's say there is a vessel here, right? Now, what is happening in ischemic stroke, guys? Due to some sort of blood flow cutoff, right? This area, now let's say this is the end perfusion zone, right? If the blood vessel is cut off from here due to some reason, the blood flow is cut off. This area doesn't receive blood, so it's going to undergo ischemia, right? And then cell death, eventually cell death. Just give me a second. Can you still hear me? Everyone can hear me? All good? Give me a thumbs up, right? Okay. Right. So what is going to happen in the case of hemorrhagic stroke, guys? In the case of hemorrhagic stroke, what is going to happen? There is a break in the endothelium. Therefore, blood is going to start extravasating, right? Now, what happens here when blood starts extravasating? One thing, yes, there will be a little bit of reduction of blood flow to the end region, right? Everyone agrees. But the difference here is, guys, in ischemic stroke, the perfusion area was the damage, right? That was the one that is causing the damage. Whereas in hemorrhagic stroke, guys, this blood, this building up of the blood, we call it a hematoma, right? This hematoma is the one that is causing the problem, is the one that is causing the neurological deficits, right? Okay, so that will exert what we call certain pressure symptoms are there, right? It can cause ischemia of other regions, close by regions, right? So in hemorrhagic strokes, that is the problem, right? So that's the difference between ischemic and hemorrhagic. Now, hemorrhagic, guys, what I want you all to know, we are not going to discuss this today, right? It's a different topic, but what I want you all to know, if you all get a patient coming in with neurological deficits, right? And they are having, you check their blood pressure, right? And their blood pressure is very high. One of the initial things you should suspect is that might be a hemorrhagic stroke, right? There are some other features, right? We're not going to talk about those today. Our focus today is ischemic stroke, right? Okay. Now, there's this. Okay. To buy a new whiteboard, no? Okay. Right. Look at this, guys. So now, let us start with the very basic, right? So we'll start with the neuroanatomy part. Okay. So what is this, guys? Stroke. There is a functional loss in the brain. So the patient is going to come to us with some sort of presentation. So if we take the basic structure of the brain, right? You all can see this. Take a better marker. You all know, you all are familiar with the structure of brain. Guys, just before we go any further, are there any first years here today? First years? Any first years? Just unmute and tell me. No first years? No, right? Shashank is here. Hi, Shashank. Right. So I'm assuming no first years, huh? Any second years? No second years? Okay. So everyone's final year. Huh? Right. Okay. Right. At any point, if you all don't understand anything, just let me know. Okay. Right. Let's go ahead. Look at these guys. Second. Right. So if you take the brain, right? What do we have? We have the cerebrum, right? We have the cerebellum here. Then we have the brain stem, right? The midbrain, the pons, the medulla, right? And then we have the spinal cord, right? Okay. Now, first thing I want you all to know, guys, one thing, what does our brain usually do if you strip down the brain's function to the absolute minimum? What do? Our brain helps us to do things, to sense things, and to think things, right? These are the three basic things, right? What do I mean by do? Motor actions, right? To move, right? To move any part of your body, right? And then sense things, right? Sensory function. And then the thinking. Thinking part, we are not going to talk about too much. We'll see some interesting things when it comes to the clinical features regarding the thought stuff. But apart from that, we are going to mainly focus on the sensory and the motor. Now, if I'm talking about motor, right? Motor functions, right? So you all know for you to move, right? Move an arm, move a leg, whatever, the signal has to originate from the brain and come down, right? And it will come down into the spinal cord and it will exit, right? Via a nerve, it will exit and come to that necessary leg or hand or whatever and give the impulse, right? It will give the message. Okay, now move, right? Same way, if we look at sensory, right? If we look at sensory, let's say the hand, right? We have some touch sensation, some pain sensation. This will enter the spinal cord and it will go up and go to the brain and give the signal. So what does this tell you? Motor signals are always descending, what we call descending, right? And sensory is always ascending, right? So since there are no first years, right? I know you all are all familiar with this part. Then guys, now I hope you all have watched the video on the homunculus, right? So I sent the video. If any of y'all haven't watched it, we'll send it again in the group, or y'all can message one of the admins, right? They'll send it to you. We've talked about the structure and the function of the homunculus. Now, what is that? We said we take the cerebrum, right? We cut it, right? We cut it in half, right? And we are going to get the motor and the sensory homunculi. And we said different areas will convert. So for example, this area is the foot and the leg, right? Then we get a little bit of the trunk. We get the hand, right? The hand. And then finally we get the face, right? Is the motor homunculus. Then in the sensory homunculus, it's a similar one. But then in the sensory, we have a genitalia here, right? But apart from that, the rest is pretty much the same. And there is a neck also somewhere here, right? Just a few differences between the motor and the sensory homunculus. But apart from that, basically they are the same, right? And we said different areas of it will indicate. So for example, if a patient comes with a leg problem, we should think there is probably some issue in this area A, right? If a patient comes with a hand or a face problem, we should think probably some area is in the, it's somewhere around the B. The problem is somewhere around B, right? So we've discussed that in that short video. Now, if you all have that understanding, right, we can move on easily. Look at this. What they found out was, guys, now this was like ancient Greek, right? Say 350, 450 BC, right? Whatever. What they found out was these physicians, when a patient came, right? Let's say those days they had all these fighting cage matches and all, still we have, right? The modern version is wrestling now, right? Patient came battered on the head, right? On one side. Let's say this is the left, this is the right, right? So the patient comes battered on the head on the one side. What happens when they come to you, when they come to the physician, they are coming with the problem in the opposite side. The opposite side is having some clinical features, right? This is what they initially noticed. So now, why does this happen? So this is where we are going to go next. Why are the symptoms with relation to lesions in the brain occurring in the opposite side of the body, right? Opposite side of the body, right? So to understand this, guys, we have to understand what we call the pathways, right? We call them tracks, right? Through the spinal cord. So we will first understand the structure of the pathways, and then we'll understand where exactly the course of the pathways, right? How they go where, right? Is everyone clear up to this point? Can you all hear me? Is the speed okay, right? Because now we are going to go into the hardcore stuff, right? Okay, all good, good. Give me a thumbs up, right? Excellent. Right. So let's start talking about the pathways, guys. Now look at this. If we look at the spinal cord, right? The spinal cord, something like this. Okay, you all know the spinal cord is, how is the spinal cord protected, guys? Any structures that you all are familiar with? Bones, anything? Or is the spinal cord just there in your back? When we touch it, we can feel it? Come on, answer. Let's be a little bit interactive. Come on. Spinal cord is protected by what? Bones. And what? Anything else? Okay, Shashank. Shashank, unmute and talk. Don't be shy. Meninges and then bones. Yes, correct. Right? So we have layers. Yes, you're correct. There are tendons as well. And we have the vertebra. So you all know in the vertebra, guys, right? In the vertebra, we have this space here, right? What we call the spinal canal, right? So through this structure, the spinal cord will travel, right? Now, what do I want you all to know here, guys? The spinal cord, it is divided into what we call segments. Spinal segments. Now, guys, don't confuse this with vertebral segments, right? Vertebral segments, we are not going to talk today. We'll talk about that in back pain, in lower back pain, then again, topics like sciatica, those kind of spinal cord issues, right? This is spinal segments, right? Spinal segments, guys, there are, how many spinal segments are there? Totally. Totally, how many spinal segments? 31, right? So we have 8 cervical spinal segments, right? C1, C2, C3, C4, like that. That is 8 cervical, 12 thoracic, right? T1 to T12, right? And we have 5 lumbar, 5 sacral, and 1 coccygeal, right? 5 lumbar, 5 sacral, and 1 coccygeal. These are the spinal segments, right? Now, what I want you all to understand is, guys, if you just take a basic look at the spinal cord, right? If you just cut the spinal cord out of someone and you take a look at it, you will see at each of these segments, right? You will see multiple nerves going out and coming in, right? Going out, coming in, both sides, bilaterally, right? Bilaterally, you will see like this, right? This is what the spinal cord looks like, right? Now, if we take a closer look at this, guys, if I cut off one of these segments, right, and I take it here, right, it will look something like this, right? Right? This is one segment cut off from the spinal cord and taken out, right? It looks something like this, right? So what you see is here, guys, in the center, you will see like this X-shaped sort of darker area, like a grayish area, right? Like a grayish area. Okay. Right? Don't worry, we'll talk about that. What you will also see is, guys, now we said there are multiple nerves coming in and going out. So you will see these nerve bundles as well, right? So they'll look something like this, right? One there, something like this, right? So this is what you will see. Now, if this was the segment that I took here, right? This was the segment that I took here. This area is the anterior, right, of this spinal segment, and here is the posterior of the spinal segment, right? Everyone agrees, right? Now, what I want you all to know is these nerves that are coming in and going out, guys, right? They have formed two main bundles, right? We call this a root, right? Inside these roots, there are multiple nerves, guys. Multiple axons are there, right? Multiple nerves are there going through these, but they have formed a root. We call one of these a root, right? The anterior root, guys, the root that is in the front, we call it the ventral root, right? We call it the ventral root. And the one at the back, we call it the dorsal root, right? Dorsal root, all fancy words, just to, someday when you're like explaining to a patient, you all can say, so you have a problem in your dorsal root, the dorsal root ganglion, something is wrong, just to scare him a little, right? Okay, just some fancy terms, nothing complex. Now, what do I want you all to understand, guys? What did we say about the sensory and motor pathways? When we consider motor, they are always descending, right? Starting from the brain, coming down, right? And going to the relevant muscle group. Whereas sensory, it starts from the outside, from the periphery, from our limbs, from our trunk, wherever. And it comes to the spinal cord and it ascends up, right? So this is the two different pathways that we talked about, right? So this dorsal root and this ventral root, guys, they serve a specific function. What is that function? If you all look at the motor, the descending one, we said motor is always descending. The motor stuff always exits through this ventral root, right? Always exits through the ventral root and goes to the necessary muscle, or at the neuromuscular junction, it will go and supply to a muscle, right? Whereas the sensory, which always comes into the spinal cord and ascends, this one always takes this dorsal root, right? They always take the dorsal root, the sensory signals. Sensory signals always coming through the dorsal root. Okay. Now, if I tell you, there are mainly, guys, if we look at our neurons, there are your nervous cells, right? If you look at the neurons, there are about 4 main different types, right? Out of that, also 3 very important types, right? Look at this, guys. One type of neuron is something like this. Something like this. Right? You can see, right? Yeah. This is one type of neuron, guys. Right? Okay, the cell body is at one end, right? Cell body is at one end, right? Then we have what we call these dendrites, these long structures, right? They connect to different other neurons, right? And then we have what we call an end plate. So this is one type of neuron. Then there's another important type of neuron, guys. It looks something like this, right? The cell body is in the middle, right? And then again, we have an end plate here, and we have some structures, dendrites, right? This is another type, right? What is the important thing to know here, guys? Our motor neurons are of this first type, this one. Our motor neurons look like this, okay? And our sensory neurons are these ones, okay? Where the cell body is somewhere in the middle. Now, according to this structure that we drew, right? If the cell body is somewhere in the middle, now, okay, let's go with our motor one first. That one is easier. So we know the motor ones start at the brain and come downwards through the spinal cord. So if they're starting at the brain, this cell body component should be here, correct? Cell body component should be there, and it should start coming down, okay? Start coming down. And here it will exit through this, the ventral root, and it will go. Whereas if you look at the, give me a second, guys. Draw the dorsal root again, right? The dorsal root looks something like this. The sensory nerves, right? The sensory nerves, guys, this guy's cell body is in the middle. So he comes like this. Cell body is somewhere here. Cell body is somewhere here. It comes out, comes in, right? If you take another one, again, another neuron, cell body somewhere here, comes in, right? Cell body somewhere here, comes in. So what you all will see in this dorsal root, guys, somewhere here along the dorsal root, you all will see a collection of cell bodies, right? A collection of cell bodies. This is what we call the dorsal root ganglion, right? The dorsal root ganglion, right? So this is a collection of cell bodies, nothing else. Collection of cell bodies in your sensory nerves, from your sensory nerves, okay? Nothing else complex here, okay? Right? Understood up to this point? All good? Right? Good? Right. Image? All good? Yeah? Okay. Excellent. Right. Now, the next important point, one more point I want you all to know about these spinal segments, guys. The spinal segments, I have put a picture in your notes, right? The spinal segments, the shape varies at different levels. So we said there are 8 cervical, 12 thoracic, right? At different levels, the shape of the segment varies, right? The shape of the segment varies. That is basically, guys, one thing is due to the change in the shape of the vertebra, right? Now, if you all take the vertebral column, right, your cervical vertebra are much more thinner and much more spread out, right? Whereas if you take something like the lumbar vertebra, they are very thick vertebra, right? So because of that, due to the change in the shape of the vertebra, the change in the spinal segments also varies a little from each segment, right? Nothing much to confuse yourselves there with, right? Don't take it as a big issue, okay? Right? Don't get confused. I have put all the segments, the different segments, an image. Don't get confused, huh? Right? So now you all know, you all have the basic idea of how the sensory and the motor enters and leaves the spinal cord, right? Now let's take a look at how these guys travel up and down, right? How they travel up and down along the spinal cord, right? Look at this, guys. Right. Look here, guys. So I will take that same spinal segment again, huh? That same one, the X in the middle, right? I will take it here. I will take 2 of those, right? Something like this, right? I have drawn this diagram in your books also, huh? In your note. Now, if we take a look at these 2 segments, now in the spinal cord, guys, these 2 segments, there is no gap here, right? There is no gap, right? Now what I've done is I've taken the 2 segments from the spinal cord and I've separated them, right? I've separated them to show a gap in the middle. If you look at this, what you're going to see, if you separate spinal segments, guys, what you're going to see are a bunch, right? You're going to see something like this, guys. You can draw, I've drawn half of the diagram, the rest you all can complete. Huh? You all are going to see bunch of neurons, basically the axon part of the neuron, right? The axon part of the neuron, you're going to see going through these structures, right? So that is one bundle there, right? Then we all want, right, another one here, right? Something like this. You all get this 3D diagram that I'm trying to draw here. I'm trying to draw 3D, right? Right? Something like this, right? So you all are going to get wires, right? So I have made something for you all to see. Huh? Yeah, I was assuming there would be a lot more first years today. Huh? So see, this is my little origami spinal cord for you all, right? That's going to be, right? But I want you all to, I want you all to understand the 3D diagram, guys. Okay, this 2D doesn't work. Okay, because specifically when we are going to talk about stroke and spinal cord disorders, also we need this, right? So you all are going to see wire-like structures through the spinal segments, right? Going through the spinal segments, right? And if you take one of those wires, right? It's actually like a wire, guys. What do we find inside a wire? Multiple tiny copper wires, right? That's exactly what we find here also. Inside one of these, this one large bundle, right? Inside one large bundle, we call this a tract. Inside one large tract, right? We get multiple small wires. These are the axons. Okay. Everyone clear about this, right? Okay. Now, if I tell you all, guys, remember we drew an X shape here, a gray color X shape here, something like this, right? This is, let's say it's grayish in color. What I want you all to know, guys, if it is grayish, these are usually cell bodies, right? These are cell bodies, the collections of cell bodies, because you all know cell looks like something like this, right? So when there is multiple cell bodies, right, it appears something blackish, grayish in color, darker in color, right? Whereas these other areas, right? These areas are white. What are those, guys? Those are the axons. So in a spinal cord section, we are going to see dark areas filled with cell bodies, this X shape, right? And we are going to see whitish areas filled with axons. Okay, everyone clear? This is your gray matter and your white matter. Okay, gray matter and the white matter. All good, all good. Right. Then, now let's take this a step further. So you all know what a tract is now. Now let's look at the main tracts in the spinal cord, right? If we look at the main tracts, guys, right? Here, let me draw this, right? Something like that, right? Right. If we look at the main tracts, okay? We have, guys, if I divide the spinal cord in half, right? This cross section, I will divide it in half. I will take it as the left side and the right side, okay? On each side, each hemi-section of the spinal cord, we are going to get 4 main tracts. That means totally how much? Main tracts, there are going to be 8, right? 8 main tracts, right? On one side, we are going to get 4. What are these 4 tracts, guys, right? We have 3 sensory tracts, and we have 1 motor tract, okay? 3 sensory tracts and 1 motor tract, okay? Right? So let's take a look at where these are and how they're working. Look at this, guys. We'll first look at the 1 motor, right? He's a single guy now. Let's take a look at him, right? Motor. This guy is somewhere here, okay? What is this motor tract called, guys? It is called firstly, if we take this as the spinal cord, right? This is, let's say this is the left side, this is the right side, right? This here, the back, this is the posterior, right? This is the anterior, right? Posterior and the anterior. And these are the lateral sides. Right? So this one right here, we call it the lateral corticospinal tract. Corticospinal. Now, do I want you all to memorize this word? No. What does this word mean, guys? What did we say about motor tracts? From where to where does it come? Starts at the brain, descends down, right? Starts at the brain, comes to the spinal cord, and then exits. So what is this? Corticospinal. Starts at the cortex, comes down to the spinal cord, and exits. That's what this term means. Corticospinal, right? That's it. Right? Now you all know the structure of the cortex. We talked about that in the homunculus. We'll come to that again a little bit today. So we start at the cortex, come down to the spinal cord, and exit. That is corticospinal tract, right? Then we'll look at the motor ones, right? Motor, we have 3, right? Look at this guy. You all can draw one here. I think I've drawn it in your diagrams already. One there, right? Something here, one here, and we have another one somewhere here, right? Look at this. So what is this one? Again, he's in the lateral. And what did we say about the sensory tracts, guys? The sensory tracts, they start at the limbs or the extremities. They come to the spinal cord and they ascend, right? So these ones, we call them the spinothalamic. From the spinal cord, they go up to the, what we call the thalamus, right? So spinothalamic tract. Okay. So we have the lateral spinothalamic tract. Okay. Then we have another one here, down here. This is the anterior. Now this was the anterior of the spinal cord, correct? The spinal segment. So the anterior spinothalamic tract. Okay. Right. So what do we have? For the motor, we have 1 tract, the lateral corticospinal tract. And the sensory, we have 2, lateral spinothalamic and the anterior spinothalamic. And here we have 1 more. This guy, he's at the back, right? He said this was the back, posterior. But we don't like to say the word posterior in medicine, right? We like to say some fancy words. So we call him the dorsal, right? Dorsal column, right? Dorsal column. Okay. This guy is the dorsal column, right? All of these 3 guys, are ascending type. They go up because they're sensory, right? They're sensory, right? They're ascending tracts, right? Now what I want you all to know is, guys, this lateral corticospinal tract does what? What is the function of the lateral corticospinal tract? What is its function? Come on, unmute. Let's talk. What is the function of the lateral corticospinal tract? Motor function. Excellent. Motor function. So something related to movement. Okay. Then, if we look at the spinothalamic, lateral spinothalamic, this is our pain, guys. This is our pain and temperature tract, right? Pain and temperature tract. It's an ascending tract taking pain and temperature information from our limbs, from our skin, from all our organs. Okay. Pain and temperature, right? Then, anterior spinothalamic tract. What is the function of that, guys? Write down crude touch, right? Crude touch and pressure. Crude touch and pressure. Crude touch and pressure. What is this crude touch, guys? Have you all ever felt crude touch before? Huh? What is crude touch? Huh? Yeah, Tarinder? What is crude touch?
Light touch.
Light touch, huh? Light touch, okay. Right? So touching the nose. Okay. So crude touch is, guys, light touch, yes, right? And we have tickling, right? Tickling sensation is also a part of crude touch. We have itching, right? Itching is also a part of crude touch, right? This is light touch. Okay. Crude touch means light touch. Correct. Right? And then pressure. Now, if we have crude touch and if we have light touch, why don't we have heavy touch, guys? Why don't we have heavy touch? Huh? Why? Right? Because, guys, now you all just imagine, you touch lightly like this. Okay, you can feel something. Then when you touch, if you touch heavily, we don't have special sensation or sensory fibers to detect heavy touch. What we have is a sensation of pressure. Our body detects it as pressure, right? So that is why, so the anterior spinothalamic tract is in charge of all forms of touch. But the heavy touch is detected as pressure. So that's why we have crude touch and pressure. We don't say crude touch and heavy touch. Crude touch and pressure. Okay, right? Right. Then we have the dorsal column. This guy is a little bit different, but we'll discuss him in a while also. Dorsal columns, guys, they transmit some special sensations, right? One is called joint position sense. What is the joint position sense? If I ask you all to close your eyes, right, and stand up, close your eyes right now from your chairs and stand up, right? You all can do it or not? You all can do it. Why you all can do it? Your body knows that, your brain knows where each of your joint is, even if your eyes are closed, right? Okay, your brain knows where each joint is. This is what we call joint position sense, right? So even with your eyes closed, you can walk. You might go and knock somewhere. That's a different story. But you can walk. You can still walk because your joint position sense is working. Okay. So that is one function of the dorsal column, joint position sense, JPS, right? The other one is vibration sensation, vibration, right? Any sort of vibration sensation, right? Right. Then 2-point discrimination, right? So you all can take, what we usually do is we take like 2 toothpicks, right? Or we take what you call a compass, right? When we are testing it on the patient, you take a compass and then you keep both points on the patient while his eyes are closed and he should be able to discriminate, right? That's saying that this is one touch using 1 point or 2, right? Okay. So all of that is done by the dorsal column. Okay. Then, guys, later, right? Now the arrangement within these, right? From cervical to sacral, we don't need to talk about that for stroke, right? We'll talk about that for spinal cord disorders, right? That's another topic. For stroke, if you all understand this is more than enough. Okay. So we are doing the relevant neuroanatomy and neurophysiology, right? No need to go excess, right? Okay. Everyone good up to this point? Give me a thumbs up, right? All good? Right. Excellent. Taimur, which year are you in? Which year?
Fourth year.
Fourth year, right? Excellent. So you all know all of it. I'm just curious. Any guys, the ones who have turned your cameras off, just turn them on, huh? Okay. Right. Okay. So we are done with the tracts, right? So now we'll see. Now we know the tracts are going up or coming down, right? We know that. Now we'll see where exactly they are going up to and where exactly they are going out to, right? Okay. Let's take a look at this. Guys, you all can do all these diagrams in your note, huh? No need to draw from scratch. I've drawn everything on your notes, right? Okay, so now let's take a look at the course of these pathways, right? How are they going through and where are they going through, right? So first, let's look at the 3 sensory ones, guys. The 3 sensory tracts. Let's start off with the lateral spinothalamic, right? Lateral spinothalamic tract, right? Lateral spinothalamic tract. Now, what is this lateral spinothalamic tract? What is it transferring? Unmute quickly. What is it transferring? What sensations? What sensations, guys? Come on. Pain and temperature. Excellent. Right. Excellent. So let's say I have my hand here. I've drawn the same hand in your note. Let's say a raccoon, right? Raccoon comes and bites me. Okay. Crazy fellow comes and bites me. Okay. Now, what is going to happen, guys? Basically, sensory fibers are going to come all the way here and they are going to go up. Let's take a look at how they are going up. I have drawn, guys, 3 separate layers for you all, but I will look at this. Let's say this is our cortex. These are cortex, huh? And then I will draw another structure here. And then here we will draw I will draw 3 of these spinal segments, right? Now what is happening, guys? Hand was here, right? Mr. Raccoon came, right? Bit my hand. Okay. Now what is happening, right? What is happening there? Look at this, guys. If we take a look at the, I forgot to draw the pathway, sorry, the ventral and the dorsal roots. I will draw that also. Right, something like that. Right. Okay. Now, if we take a look at this, right? So our sensory nerve, right, our sensory nerves, right, they will detect this pain sensation, right, from their nerve end plate. They will detect they have the receptors there at the end plate. They will detect the pain sensation, right? And there will be a neuron, right? There will be a neuron that is bringing this information. Now, the neuron travels through what, guys? The dorsal root or the ventral root? The sensory neuron? Dorsal root or the ventral root? Huh? Dorsal root, right? Dorsal root. Good. So we are coming through the dorsal root. Somewhere here, the cell body is there, right? That will form the ganglion. And this guy comes in. He comes into the spinal segment, right? Here, I will draw that X shape again. Right? Something like that. Right? Now, pain and temperature, guys. Pain and temperature was transmitted by what tract? What is the name of the tract that transmits pain and temperature? What is the tract?
Lateral spiral.
Excellent. Lateral spinothalamic tract. So now what is going to happen, guys? This guy is going to come, this neuron that came from all the way from the hand. He comes all the way to the spinal cord. And here in this X portion, right, in the gray area, he will meet a cell body. He will meet another cell body of another neuron, right? Okay. And that neuron will cross the midline. He will cross the midline, right? This is the midline of these are the midlines of the, right? Spinal segments. That neuron crosses the midline, right? That neuron crosses the midline. And here, what did we say? Our tract was there. Our spinothalamic tract is there, right? This guy is here. Spinothalamic tract is somewhere here. And this guy will come to this spinothalamic tract here, and he will start going upwards, ascending upwards. Okay. Did everyone understand? The first neuron was here, right? From the pain sensation all the way up to the spinal cord, there was one neuron. Then at the gray matter, he synapsed with the second neuron. That second neuron immediately crosses, right? Is it clear for y'all guys? Here, let me draw it here, somewhere here, right? If it's like this, right? And the spinothalamic tract is somewhere here. Let's say somewhere here, spinothalamic tract, right? So, right, something like this. This guy came all the way like this, right? And he met a second neuron here. He met a second neuron there. And the second neuron crosses the midline, comes to the spinothalamic tract, and then ascends upwards, right? Ascends upwards. All good? All clear? Right? Now, there are other fibers, huh? There are other fibers going. This was just the fiber necessary for the pain at that area, right? Sensory area. So if I take my hand, you all, my seniors, you all know, around where C is, somewhere here, C7, C6, C7, C8, right? That's here. Okay? So, this will ascend upwards like this. All good, right? He will actually, let me draw it clearly, something like this, right? Okay, let me draw it nicely for you. That. And goes up, right? Okay, like this, right? Right. Now, this second neuron, guys, the second neuron that crossed the midline and went up, he is going to come to this structure. This is what we call the thalamus, right? Thalamus. This is why we call it the spinothalamic tract. From the spine, we are coming to the thalamus, right? Spinothalamic tract. Okay. And he comes to the thalamus, right? And he synapses with another neuron. He synapses with another. So this is which one? Third neuron. This is the third neuron. Okay. He synapses with the third neuron. Okay. And he then goes to Perera. Now this was the hand, right? If you all remember the structure of the homunculus, the sensory homunculus, the hand was somewhere here, right? Hand was somewhere here. So this guy will go to that responsible area and relay the signal, right? Relay the signal there, right? Everyone clear about this? Okay. So what is the important thing I want you all to know here, guys? In the lateral spinothalamic tract, the pain and sensory information that comes, right, at the particular level, it immediately crosses to the other side. So this was my left hand, the pain sensation that came from my left hand immediately crosses to the other side, to the right side, and then ascends and goes to the right cortex. It goes to the right cortex. Okay. So left hand sensations going to the right side cortex. Okay. Is that clear? Is that clear? Right? All good. Everyone could give me some thumbs up. I want to make sure y'all are not going to faint, right? Okay. All good. Right. Now, okay. So that is the lateral spinothalamic tract. Now let's take a look at another one, guys. The next one. Let's take a look at the anterior spinothalamic tract. What does the anterior spinothalamic tract transfer? What information? What information? Come on. Anterior. Huh? Tell me.
Crude touch and pressure.
Crude touch and pressure. Excellent. Lisa, which year are you in? Which year?
I'm doing my internship
Right, excellent.
year.
Right, excellent. Any of you, right? NMU? Yeah, okay, good. Right, look at this. Proud alumnus, huh? Good. Right, okay. So anterior spinothalamic tract, right? Crude touch and pressure. Excellent, right? So let's take a look at this, guys. Again, these are ascending fibers, right? Ascending fibers, but here there is a little bit of a difference. If I take 3 of these, huh? Like that. Right. Right. Okay. And let me draw the X in the middle. Guys, don't call this the X, huh? This is the gray matter, okay? I had this issue in one of my previous classes also, huh? Don't call this the X, okay? At least not at exams, okay? Right? Okay. X can't be in the center anyway, no? Right, okay, look at this. So, here, there is a small difference, guys. Now, let's say, okay, I think I've drawn, in your note, I think I drew an armpit, right? Sorry if that doesn't look like an armpit, right? I don't know, right? Okay, so someone's tickling you, right? Someone's tickling you, right? So we get this sensation, right? This sensation is coming in. And let me draw the dorsal and ventral roots, right? Something like this. Now, what do we know? Sensory nerves always take the dorsal root. So let's say like this, the neuron comes, right? The neuron comes here, right? The cell body is somewhere here that will help form the dorsal root ganglia, right? And he will come in. He will come in, right? Now, what is the difference here, guys? Here, as soon as he comes, he is going to meet the second neuron. He's going to meet the second neuron, right? But this second guy for the anterior spinothalamic tract, the ones that are transferring crude touch and pressure, these guys don't cross immediately. They don't cross immediately, right? What they do is, guys, they ascend, right? We say about 2 to 3 levels, right? About 2 to 3 levels before they finally meet the anterior spinothalamic tract, right? So here, this guy misses the anterior spinothalamic tract. Anterior spinothalamic tract is somewhere here. He misses that. And finally, out of the, about 2 to 3 levels above, he will meet the anterior spinothalamic tract and then he will ascend upwards. Okay, right? Did everyone understand this, guys? Here, what we say is they cross obliquely. We say this is crossing obliquely. How was it in the lateral spinothalamic tract? He came in immediately crossed at that level. This guy crosses obliquely about 2 to 3 levels upwards and then travels up. Now, why this is important? We will see, guys. For example, if we have a lesion somewhere here, you have to understand that 2 to 3 levels below that, you will have the sensory deficit. Okay, that is how it works in the spinal cord, right? We'll talk about that in spinal cord lesions, not today's chapter, but I want you all to get this basic picture, right? It crosses obliquely about 2 to 3 levels up and then travels all the way to the, again, same, again, it goes initially where? These are spinothalamic tracts, right? These are anterior spinothalamic. So it goes to the thalamus, meets the next neuron, right? And from there, it goes to the cortex, the responsible area. So these are again, the armpit, right? Somewhere around the trunk area, right? Somewhere here, arm is a little bit here, right? Somewhere there. Okay. And again, what is the important side? Left-sided arm, signals come to the right-sided cortex. Okay, somatosensory cortex. Everyone understood this? All good? Guys, give me a second. Is my internet lagging? Give me a second. Can you all hear me? All good? Right, okay. Right. Guys, was it lagging before? No, right? Okay, right. Excellent. Right. So, yeah. So this is the anterior spinothalamic tract, right? Right. Then we'll look at the third one, guys. What is our third one? This is our weird guy. He's the dorsal column. Little bit weird, right? Look at this, guys. This guy, now, what did we say? This is dorsal column responsible for joint. I think I've drawn a knee, right? A knee joint. So responsible for joint position sense, vibrations, touch, 2-point discrimination. Let's look at the joint position sense, right? What is going to happen here? I'm not going to draw all those layers again, guys. Basically, right? If we look at this, right? This guy, right, will come, right? Again, he will take the dorsal root, right? Cell body will be somewhere here, and he will come in, right? He will come in. This guy, the important thing is, guys, he doesn't even meet a second neuron here. He goes all the way up. The same neuron, right? Comes into the spinal cord and immediately starts on that side itself. Now, this was the left side. This is left. This is right. Okay. On that side itself, he starts ascending up, right? Along the dorsal column, right? The dorsal column is somewhere here. He'll come to the dorsal column, start ascending up, and he will come to a structure here called the medulla, right? I will draw the medulla like this. You all know these are part of the brainstem, midbrain, pons, and medulla. Right? We'll come to the medulla. Come to the medulla, and here he will meet the second neuron. He will meet this second neuron. Okay, okay, and this second neuron will immediately cross. The second neuron will immediately cross and then go up, go to the thalamus. We have our thalamus somewhere here, right? And at the thalamus, right, he will meet the third neuron. He'll meet the third neuron, and that guy will go to the, right? That guy will go to the, oh, this is the leg. Now, if I draw the thalamus like this, A, B, C. If this is the thalamus, if the signal is coming from the leg to the somatosensory cortex, which area? A, B, or C? A, B, or C? Come on.
A.
A. Excellent, excellent. So this is our homunculus, right? From our homunculus, right? He comes, goes all the way to this A area, right? And he will relay the signals. Okay. Everyone clear about this? Now now we are done with the three sensory nerves. What do I want you all to know here? Remember, we saw a first nerve, and then we see a second nerve, and we see a third nerve. So the sensory input, right, comes via three nerves, right? We call these the order, guys. This is the first order nerve or the first order neuron, right? Then here we get the second order, right? Second order, and this is the final one is the third order neuron, right? So now the first order, second order, and third order, the neuron length varies depending on the tract. So in the anterior spinothalamic tract, the first order neuron is very long, right? Very long. Whereas in the other ones, like the lateral spinothalamic, what happens? They come here. This is not the anterior, no, guys. Sorry, this is the dorsal column. Huh? In the dorsal columns, right? The first order neuron is very long. Whereas in the anterior spinothalamic tract or the lateral spinothalamic tract, the first order neuron is much shorter. Now, this is also important in certain clinical aspects. We'll talk about those later, huh? Right? Right. Okay. So we are done with the sensory tract. The ascending tracts are done, right? Now, we'll look at the motor tract. There's only one motor tract to look at. Look at this, guys. Motor tract is what? Always starting from the brain, starting from the cortex, and coming down, right? Here, there is some additional structures. So let me start from here. I will start. This is our cortex. Here, guys, there is a very interesting structure here, right? Something like this, right? Okay, and after that, we get the midbrain, the pons, and the medulla. I'll draw that in a different color, right? Midbrain, pons, medulla, right? And finally, we get the spinal cord, right? Something like this. Okay, now, right? Okay, so I put this diagram also in your note. Huh? Now look at this, guys. This is the lateral corticospinal. Lateral corticospinal tract, right? Lateral corticospinal tract, guys, right? So we are starting off at the cortex. We're starting off at the cortex. Now let's say I want to move my arm, right? Let's say here, say I want to move my left arm, right? This is the left arm upwards. So I need to contract my bicep, right? The forearm. I want to move my forearm upwards. So I need to contract my biceps, right? So from somewhere, the signal must come and tell my biceps, okay, start contracting, right? Right. So we start off at the motor cortex, guys. Now, if anyone who watched the video, motor cortex is there in which gyrus? The motor cortex? Huh? The motor cortex. Excellent. Precentral gyrus, right? It's in the precentral gyrus. So in the precentral gyrus, whichever area is responsible for the hand, let's say the hand is somewhere here. And we are starting off, this is the left hand that leads the signal. So the start off will be on the right cortex, right? The right cortex. So he will give, right? There will be one neuron starting here, right? That is firing, right? And now from here, guys, he comes to this other structure. This is what we call the internal capsule. What is this internal capsule, guys? This is sort of like a radiation, right? What it has is, it has areas divided for different functions, right? What do I mean by that? Wait, let me draw it. Right? Something like this, right? Multiple areas. So this area, right? This area, let's say, is responsible for the face. This area responsible for the foot, right? Somewhere here, hand. Like that, it has different areas to group. Why the importance is, I will show you all in a minute, right? For now, just know it has different areas classified. So like the homunculus classifies different areas of our body, same way, this internal capsule also has different areas classified for different areas of the body, right? So Now this hand, the neuron coming from the hand area of the homunculus will come to the hand area of the internal capsule, right? Come to the hand area of the internal capsule of that side, the right side, right and left, right? And from there, right, it will come down. It will come down. Now here what we have, midbrain, pons, medulla. From here, guys, it comes all the way down to the medulla, right? Then at the medulla, it crosses. It crosses the midline. This was the midline, right? It crosses the midline. At the lower border of the medulla, it will cross the midline. And then it will travel down, right? Now, if you all remember our initial X diagram, right? Right? Or like that. Something like this, right? Something like this, right? Look at this. Our lateral corticospinal tract was somewhere here, right? Same in this, right? And then, if you all remember, we had our roots. Right? Now, if you all remember, guys, so the lateral, this guy will come all the way down here, right? Now it will come from there, it will come down here. The necessary level for our bicep, it will come to our necessary level. Now for the bicep, guys, around C5, C6, right? Around C5, C6. So let's say this is a C5 segment, right? What is the nerve? You all remember, musculocutaneous, right? Musculocutaneous needed for biceps contraction, right? Okay. So this guy comes here. Now at this level, at the relevant level necessary for this muscle, this guy has to exit. How does he exit? What he does is, guys, he gives, right? He comes out of the spinothalamic tract. He comes out of the corticospinal tract. Okay. And in the corticospinal tract, he will meet another nerve. Right? This guy. He will meet another nerve. And what did we say about the motor ones, guys? We said the motor always takes the motor ones always takes the ventral route. It takes the ventral route. So this new neuron, the second neuron here, will come out of this ventral route and come all the way and give the signal to the bicep. Okay. He comes out of the spinal cord, comes out of the ventral route and goes and gives the signal. Okay. Understood. Now, what is the importance here, guys? What I want you all to understand is at each level, we will see this happening, right? So different spinal nerves, all the way coming from up, right? Now, let's say here there was another problem. We wanted to move some part of the shoulder, right? So there will be from this one, there will be another branch, right? And coming and supplying like that to the shoulder. Okay. So here, what are you seeing in the motor system, guys? There are two neurons, only two neurons. There are sensory, we had three. And here, guys, the two neurons, we name them. Whichever is in the central nervous system, we call them the upper motor neuron, right? And whichever is leaving outside, whichever is leaving the spinal cord outside, we call this guy the lower motor neuron. Okay, lower motor neuron. Okay, understood, right? So now tell me this. One more thing I want to tell you all about this, right? The internal capsule. Why is this internal capsule here, guys? It's basically like a sorting system, right? Now you all know, let's say there was some face problem. We wanted to move some muscles in our face, right? This internal capsule has multiple areas now, guys. The top of the face, the nasal area, the near the eyes, right? Even when I'm making facial expressions, right? Multiple areas. So all of these wires, so many wires have to come down. And if they come down all at once, what will it be? It will be such a mess, right? So what the internal capsule does is, guys, it's like a sorting area. It brings all of these neurons from all of these areas coming to this one area, and then from there nicely descending down as one line, right? So this internal capsule acts as sort of like a sorting place. Okay, there are some other functions, right? We'll talk about this later, but for now, that's enough, right? Okay. So what was the upper motor neuron? Whichever motor neuron was within the central nervous system, right? So starting from the cortex all the way down to the spinal cord. Whichever nerve is exiting the spinal cord is the lower motor neuron. Now, when we talk about stroke, right? Our chapter today is strokes. And if we are talking about motor symptoms related to stroke, movement symptoms related to stroke, what motor neuron do you think is affected? Upper motor neurons or the lower motor neurons? Based on this, what we have studied. Come on, tell me. Upper motor neurons. Strokes always include upper motor neuron type of symptoms. Okay, this is what you see in strokes. Everyone clear? Right? Okay. Right? Okay. Give me a thumbs up, guys. Oh, good. I'm scared. Yeah, excellent. Right. Who else is here? Dilmi Tilakaratna. All good. Which year are you in? Which year? 5th year. Excellent. Okay. Right. Guys, don't we have any first years? That's the real challenge, you know, having first years, right? That's the challenge that I love. Right? Okay, okay. Who's this? Right, okay, okay. Guys, yeah. Yeah, no problem, no problem. Timur, okay, no problem. Yeah. Right, okay. Right, let's continue. You shouldn't join my classes in the library, yeah? Right? It's okay. Right? Okay. Now, how will the patient come to us, guys? How will the patient come to us? If we are talking about movement problems in a stroke, patient will come to us with upper motor neuron type of features, right? What are these? This is our next part, guys. Now I put a table, right? You can write down in the table, right? Upper motor neuron features versus lower motor neuron features. Our stroke patient always comes with upper motor neuron, right? Okay. So how is he going to come? If you do, we'll do a short case discussion later. I will show you all the patient demonstration, right? There are some plans. In some upcoming classes, right? We'll see how it goes, right? Upper motor neuron and lower motor neuron. So first thing is, guys, you're going to check the patient's tone, right? Tone, right? If you check the tone in upper motor neuron, guys, they are very rigid, right? They are very rigid, very increased tone, right? Whereas lower motor neuron lesions, guys, reduced tone. The tone is reduced. So if you try to move the patient's arm, right, in an upper motor neuron lesion, it will go very rigid, right? Whereas in the lower motor neuron, it's just falling down, right? Okay. So very rigid in upper motor. Tone is increased, right? Then if we look at the reflexes, guys, reflexes. You all know the reflexes, you all use the tendon hammer, right? Tendon hammer. Yeah, I have one here, tendon hammer. So you use the tendon hammer and you hit, right? So the brachioradialis, you all can check the biceps, you all can check the triceps, knee jerk, right? All of these. You check the reflexes. In upper motor neuron, guys, reflexes are also exaggerated, right? Exaggerated, that's the word we use, exaggerated. Whereas in lower motor neuron, again, reflexes also reduced. Okay. Now, there is something called clonus, guys. Clonus, right? These are involuntary rhythmic movements that appear when you do sudden jerky flexions and extensions in the patient's body, most of flexions, right? So you will see something called the ankle clonus, right? The ankle is like this. You suddenly push it back, the patient's ankle will start jerking on its own, right? Same with the knee, like a knee joint clonus, right? We'll show these to you all in a different patient demonstration session. Yeah, right. For now, just know there is something called clonus in upper motor neuron lesions. Clonus is positive. Here, clonus is negative, right? Okay. Then, guys, you all also know these pathologic neuronal signs. What do you call Babinski sign? Babinski sign is positive in upper motor neuron lesion, right? And again, here it's negative, right? Babinski sign. Okay. Now, if I ask you all, power, I haven't taught this to you all, power, right? Power. What is the upper motor neuron and lower motor neuron types of lesion? How will it manifest in terms of power? What do you all think? Come on. Sorry? Prashan, I didn't hear you.
Reduced in both.
Excellent. Excellent. Stroke is causing what, guys? Neurological deficits. If we have low motor neuron, we talk about spinal cord in a different section about the spinal cord lesions, right? Brown cord, those kind of things. Again, there is going to be reduced. Both have reduced power, right? Both have reduced power. This is why we say the word weakness for both, right? Weakness. That's how we explain it, right? So we say upper motor neuron type weakness, lower motor neuron type weakness, because both have a reduction in power. Both have a reduction in power. Okay. So except for power, how can you all remember upper motor neuron? Right? Everything is going up, right? That's how I also remember. Everything is going up. Tone, up. Reflexes, up. Babinski positive means what, guys? Now your foot, if this is your foot, Babinski positive, you're going to take a sharp key or something, right? And through the lateral aspect of the foot, you're going to drag it along up to the toes, right? What is a positive Babinski reflex? The toes start fanning out, right? The toes start pointing upwards, right? Whereas if you do it in you and I, a negative Babinski is the toes reflex, right? That's a negative Babinski, okay? So even Babinski is technically going up. So just remember upper motor neuron, everything is going up, okay? Except for power. Power in both is low, okay? Except for power, everything going up. Okay. Now, both were weaknesses, right? Both were weaknesses. But upper motor neuron, what did we notice? Very rigid, right? So what do we call this type of weakness, guys? We call it a spastic type here, right? Spastic type of weakness. Spastic type of weakness. Very rigid type of weakness for upper motor neuron, right? Whereas for lower motor neuron, guys, we said the tone is reduced, right? Reflexes are reduced. So this is what we call a flaccid type of weakness. Flaccid type of weakness. Okay, right? Another important thing about lower motor neuron, guys, this is just extra for you all to just understand. If the tones and the reflexes are reduced, what do you think about general day-to-day activities? Right now, let's say the patient wants to, let's say his right arm is affected, right hand is affected, right? And he wants to take a cup of tea. Will you think he prefers to use the right hand or the left hand? He will obviously go with the left hand, right? So what is happening, guys, when there is this, especially this lower motor neuron type weakness, because it's a very flaccid type of weakness, no energy at all, right? They are going to get what we call a disuse atrophy. Disuse atrophy, right? Now, this can happen in upper motor neuron as well if physiotherapy is not done, right? But it's more commonly in lower motor neuron, right? We'll talk about that later. In upper motor neuron, this is why we have to do physiotherapy after a stroke, right? We'll talk about those later. But you see this disuse atrophy commonly in this lower motor neuron type. Okay. So you say wasting, and what we call fasciculations, because their muscles are getting so weak, their muscles just start twitching. Like they want to extend their hand, right? The triceps need to contract properly, but it will just twitch. It won't contract nicely. It will just twitch. So we call it wasting and fasciculations are commonly seen in lower motor neuron type of lesions. Okay. Okay. Is everyone clear about it? Now, our topic is what? Stroke. Always upper motor neuron. Okay. All good. Is everyone clear up to this point? Huh? Give me a thumbs up. Right. Okay. Excellent. Excellent. Right. So now, another important thing, guys, I want to mention here, when we take strokes, right? Now we said there is going to be a weakness. There is going to be a spastic type of weakness, right? Here, this weakness, we can further classify it into two. Weakness, we can talk about paraparesis. Paraparesis. Okay. Paraparesis is one type of weakness, and the other one is paraplegia. Paraplegia. Plegia. Right? Now, in terms of stroke, what did we say? Stroke always, when the symptoms come, it is in one half of the body, right? It is in one half of the body. So we change this word a little bit. We put the word hemi. So it can be hemiparesis or hemiplegia, right? Hemiparesis or hemiplegia. What's the difference between this paresis and this plegia? What do you think? Paresis versus plegia. Anything? Huh? What's the difference? Paresis is, guys, paresis is reduced muscle power, reduced muscle power. Plegia is complete. The muscle power, if you grade it, it's zero, right? Complete loss of muscle power, right? Complete inability to move is the plegia, right? So hemiplegia, hemiparesis, right? Okay, right? Okay. Then, now I have put a picture, guys, of how the patient comes to you. Now we said upper motor neuron type lesions, very spastic, right? Spastic. Tone is high. So you always see, guys, specifically, right? The upper arms, right, of the affected side. Now, let's say the stroke was in my left side, right? Guys, you all can see this as the left, right? When I point this, do you all see it as the left? Yeah, I'm hoping so. Okay. Yeah, this is the left side. Okay. And the patient will come with right arm, his right arm, right hand, right, will be flexed, right? Abnormal posturing. He will be flexed. Why? Very spastic, right? And the leg, guys, let me share this, guys. Then I can explain it to you all better. Give me a second. Let me share the screen. Where's this? Share. How do I do this? Ah, there we go. Okay. Getting old, guys. This technology is, huh? I'm not that old, huh? Okay. Right. Can you see the screen? Yeah? All good? You can see the screen? Yes, give me a thumbs up. Y'all can see the screen? Yeah, excellent, excellent, excellent. Look at this. Oh. Give me a second, guys. Yeah, there we go. Okay. Look at this, guys. Can you all see what I'm writing? Right? Yeah? Okay. Right. So look at this. What is going to happen, guys? One thing you're going to notice is his upper limb is going to be flexed, right? Upper limb is going to be flexed on the affected side. Now, the lower limb, they are going to have the weakness again, but this is going to give rise to a specific clinical feature, which is the gait, right? Very important to understand this gait. Now, what is happening? let's say now this is his right side, right? That means he has had a left-sided stroke. Right? His right side leg will also be having this spastic weakness, right? What is he going to do to move this leg now, right? Now, out of all the muscle groups in the leg, guys, what is your largest muscle group? Your thigh muscle group, right? Your thigh muscle group is one of your largest muscle groups in the leg. So the patient is going to use the assistance of that largest muscle group to start moving, right? So what he's going to do is, guys, he's going to use these thigh muscles initially to try and lift the leg off the ground a little bit. So you all can see the leg is slightly being raised off the ground, right? Using the thigh muscle. So when he does that, when you all can try standing up and doing this, right? You all try and use the thigh muscle to raise the leg. What will happen? The body will slightly slant to this side, right? The body will slightly slant to that side. That's why we give them a walking stick, right? Otherwise, no balance, right? Right. Then what is he going to do now? Now, for you all to walk, guys, right? Do you all want your toes dragging along the floor, or do you want to nicely lift your leg and keep it in front? You want to lift your leg and keep it in front, otherwise you'll be dragging your toes along, right? So now he has to take the toes also upwards, right? So to that, he doesn't have the energy on that affected side anymore to take the toes off the ground. So what he does, his other foot goes onto the toes, right? His other foot now goes onto the toes to try and elevate the affected right-sided limb, right? Okay, left-sided foot goes up, okay? Then guys, if you look from the front, now once the toes of this right-sided affected limb is up, he can move them forward. But to move it forward, he needs good muscle tone. He needs good muscle power, right? In the thigh muscles. So, but there's insufficient. So what you will see is this will go in front in a curve, right? They have drawn it here in the other direction. It will come in a curve, right? Okay. What do we call this, guys? We call this a circumduction. Okay. Circumduction gait, right? This is the classic hemiplegic gait, right? Arm is flexed, abnormal posturing, right? Arm is flexed, and as well as the wrist also can be flexed, right? Depending on the severity, right? And then you will have classic circumduction gait, or what we call the hemiplegic gait. Okay, right? Everyone understood this, right? This is due to the upper motor neuron type of spastic weakness. Okay, right. Then come to the next one, right? Now you all know what the patient's body is going to present like. We understand. How is the patient's face going to come to you? Now, when the patient comes to you guys, right? One thing you can look at is the body. The other thing, before looking at the body, you should always look at the face first, right? So, we'll look at the face, right? Okay. Look at this. I have drawn the diagram in your note. You all can just follow along. Let me erase this. The face is a little bit different, guys, because the face has the involvement of what we call a cranial nerve, right? A cranial nerve, what we call, right? A facial nerve. We'll take a look at that. But basically, again, we'll first discuss about the motor aspect, right? The muscle, the motor aspect of the face, right? So what we are going to see is, guys, let me draw the precentral gyrus, right? The homunculus, right? And then again, when we talk about motor, we always have the internal capsule. Right, we have the internal capsule, and then we have the midbrain, the pons. I'll draw the pons a little bit bigger because that's the guy we need, and the medulla. Right, midbrain, pons, and the medulla. And then I will draw face here. Right, face here. Right, and the face will divide it into half. Right, from the nose. Right, something like that. And we'll divide it here also into the upper and the lower face. You all will see why. Look at this, guys. Now, if we take a look at the face, right? You all remember in the homunculus, somewhere here in the lateral part, right? Somewhere here, right? Somewhere there, right? This was the face associated region. Now, what I want you all to draw is, guys, take 4 colors, Take 4 colors because otherwise the diagram will get a little bit messy, right? So I will also use 4 colors, right? Look at this. Firstly, let's say there is a new neuron starting here, a motor neuron starting there, right? And it will come all the way. So this is the right side. This is the left side. Okay. It will come all the way to that relevant part in the internal capsule, the face area of the internal capsule, right? Okay. And it will cross, guys. After the internal capsule here, this guy will cross, right? He will cross, right? And he'll come down all the way to the pons. Okay. This is the pons. In the brainstem, you know, there are 3 parts, midbrain, pons, and the medulla. He comes to the pons. Okay. At the pons, guys, he will meet the lower motor neuron, what we call the lower motor neuron. Okay. What is the feature of the lower motor neuron? Always it exits. It exits the central nervous system, right? So this lower motor neuron comes like this, right? It exits out of the pons, right? And what happens, guys? It will give a supply, one to the upper half of the face and another one to the lower half of the face. Now bear with me, don't be confused, right? We'll go at this slowly, right? Then, right? What is the important point, guys, with regards to the face and these cranial nerves? The face, now this is let's say this is the left half of the face and this is the right half of the face. The left upper and the lower half of the face got some nervous input from the right cortex. Okay, everyone agrees? What is the difference, guys? There is also another accessory input coming from the left cortex, right? What am I saying? Look at this. From the left cortex, we have another nerve, right? Coming all the way down, it will come to its internal capsule, right? And that guy doesn't cross, guys. That guy doesn't cross. He will come all the way on the same side. He will come to the pons. He will come to the pons where he will meet another neuron, right? And that guy, the black one, he will come and supply only to the upper half of the face. Only to the upper half of the face. Okay. Now, what does this diagram tell you, guys? If we take one half of the face, that means if we take the left hemiface, if we take the left hemiface, the upper half of that left face is getting a dual motor supply. One from the right cortex, one from the left cortex, right? Whereas the lower half of that left face is getting only a single supply. Okay, everyone understood? Everyone understood? Right? Okay, then you all can draw the same way, guys, going to the other side also. What do I mean by going to the other side? Let me draw one here, right? From the left, we will have one coming like this. That guy will cross. That guy will cross, come to the pons, right? Meet the second neuron, or what we call the lower motor neuron, right? And he will go all the way down, and the one that crosses supplies both the upper and the lower face. Also, what do we have? We have one coming from the ipsilateral side, right? Okay, this guy doesn't cross. He doesn't cross, right? It directly goes, and he supplies only to the upper half of the face. Okay. He comes to the pons, He crosses at the pons, He exits at the pons. The lower motor neuron exits at the pons, Okay. Right? Okay. Now, what is the importance of understanding this? Let's say, guys, is everyone still drawing? Y'all can take time and draw later. Now just understand. Okay. Okay. Also, we are thinking of restreaming this. We'll see. Okay. Look. Everyone still drawing? Okay. Okay. Let me see some faces. Kasuni, which year are you in? Which year? Fourth year. Which university?
Tianjin Medical University.
Right. Excellent. Excellent. Okay. Okay. Right. Right. Look at this. Let's take a look at this. Now, I am going to tell you all, okay, this is my patient. He has a right-sided stroke in the motor cortex, right? There is a right-sided stroke here, right? So let's say somewhere here, this area, there was a stroke, right? This area, there was a stroke. Now, guys, if you follow, right? If you follow this red and now this area, red and the blue, I hope you all can see the red and the blue in my diagram in your screens as well. If you follow the red and the blue, what are you seeing? If the stroke is here, okay, this red is gone. Okay. This red is gone. Right? And this blue is also gone. Okay. Okay. Three supplies are gone. So what do I mean? Left-sided upper and the lower face. In the upper face, one of the supplies are gone. Lower face is gone. And in the right side, on the ipsilateral same side, one of the supplies is gone. Okay. Now, if we look at this left-sided lower face, it had only one supply, one motor supply. And that one motor supply was gone. So can that left-sided lower face do any motor function anymore? No. That left-sided lower face will not have any motor function. Okay. Right? But what about the left-sided upper face? True. The red color one is gone. But we get an ipsilateral supply from the ipsilateral cortex. Right? We get another supply. Right? So therefore, the left-sided upper face can still function. What about this guy? True, this blue one went. The blue one is gone. But there is a second supply coming from the left cortex, right? So this guy, the right-sided upper face also can function. Okay. So in a stroke, guys, stroke is what? Always upper motor neuron lesion. In a stroke, what do we get in the face? What do we get in the face? Contralateral side, right? Contralateral. So if the stroke is on the right side, we get a left-sided contralateral side, lower face motor function loss, right? Lower face motor function loss. Again, we call it lower face hemiparesis or hemiplegia. Okay. Understood. Right? Now we have created our stroke man. What do I mean by our stroke man? We have initially talked about the limbs. When we get, let's say we have a right-sided stroke. What did we say about the limbs? About the limbs, right? Contralateral side, limbs are affected, right? And the face, contralateral side, lower half is affected, right? This is our stroke patient. This is how he comes, right? Okay. Is everyone clear why our patient is coming like this? I don't want you all to memorize stroke, contralateral side, lower half of the face, stroke, contralateral side, body affected, right? I want you all to understand why. Okay. Why? All good. Clear up to this point? Give me a thumbs up, right? Excellent. Right? Okay. Give me a second, guys. Right. Okay. Now, guys, just for your knowledge, it's not our topic today. If there is a lower motor neuron type facial nerve weakness, right? Or lower motor. Now, what is the lower motor neuron, guys? This entire thing is the lower motor neuron, what we call as the facial nerve, right? Our facial nerve is a lower motor neuron, facial nerve. This is the cranial nerve 7, right? So if we have a lower motor neuron type facial nerve weakness, facial nerve, what we call a palsy, right? What is going to happen? Let's say the left-sided facial nerve. What are you going to see? Someone just unmute and say, 4th, 5th year specifically. I don't want 1st to 3rd year. It's okay. Come on. Unmute and talk. If we have a facial nerve.
The whole face, the half of the face will be affected.
Right. Good. Excellent. Who answered?
Me.
Lisa. Okay. Right. Let's put it in a little bit. We like to scare patients now. We are physicians now, right? We have a role to play in scaring the patients. So how can you say this in a little bit of a nicer way? The left side facial nerve involved, right? Left side facial nerve has a problem. How do we say that? The patient will have ipsilateral side. That means the same side, left side, hemiface, entire half of the face, top and the bottom will be go. Okay. That's how we say ipsilateral hemiface weakness, right? Okay. Right. That's not today's topic, huh? You can forget about that. Today is upper motor neuron. Stroke is only upper motor neuron, right? Okay. So now what do we know, guys, up to now? Up to now, we know when a patient comes to us, right? He's going to come with some sort of weakness. I can't move my leg. I can't move my hand. He's going to come with some sort of sensory problem, right? Then we know where in the brain, using our homunculus diagram, we know where in the brain this lesion might probably be, right? That much we know. Then we know why it is on the opposite side. We have seen the tracks. We have seen where they cross the midline and go to the opposite side. So what I want to do next is take it a step further. Now we'll take it a step further. We'll see which blood supply was exactly responsible. Why? We said stroke is a vascular event. It's an acute vascular event. So we'll see which blood vessel was involved and which gave rise to this infarction or ischemia, right? Okay. So for this, guys, I have put a diagram of the brain circulation, right? Now, I'm not going to draw that, right? It took about a good half an hour for me to draw it onto your notes as well, right? Let me share the screen, right? Where is this? Give me a second, guys. Right. Guys, can you all see the screen? Wait. Let me take it here. Okay, I can't see you all now. Where are you all? Give me a second. To see your faces as well. Okay. Right. Can you all see the screen, guys? Give me a thumbs up. Can you see? No, not yet. Not yet. Ah, right. Okay, excellent, excellent. Okay, y'all can see me also on the side, or it's just the screen? Y'all can see me also. Good, good, good. Right, no need to see me anyway. Right? Okay, let's take a look at this. Right. Look at this, guys. So this is our, we are starting all the way from the bottom, right? From the heart itself, we will start, right? And we'll go all the way to the top. Y'all can see what I'm writing, right? Y'all can see what I'm writing? Yeah, okay, right. Look at this. Let's start from here, guys. So this is our heart, and this is the aorta coming out of the heart, right? Aorta coming out of the heart. Now, so if we take a look at these branches, right? Initially, we all know this. Even last week's ischemic heart disease, we talked about these main three vessels, right? So here we have the subclavian, right? So this is the left and the right, left and right side, right? So here we have what you call the left subclavian, right? The left subclavian, okay? Left subclavian. Then here, guys, this is the left common carotid, okay? And then here this one that is coming out here is called the right brachiocephalic trunk, right? And out of the right brachiocephalic trunk, we get the right common carotid, okay? And here we get on the most lateral aspects, right? We get the two vertebral arteries, right? So the left and the right vertebral, okay? Right? The left and the right vertebral arteries. Now, look at this. If you all can see, guys, just from how I've drawn the diagram, can you all see that the common carotids appear to be a little bit more forward, right? They appear to be a little bit anterior compared to the vertebrals, right? I hope you all can get that from the diagram. We will look at the 3D structure next, right? So the common carotids are a little bit anterior, whereas the vertebrals are a little bit more posterior, right? Okay. Then as we go up, the common carotid here, it divides into two, guys, right? The internal and the external carotid. Now the external carotid, we do not need to talk about. That's not related to our stroke, right? What we need is this internal carotid, right? This side also same too, right? Internal carotid, right? And then here, the vertebrals, guys, they came all the way like this, right? They came all the way like this, and they join at this point to form what we call the basilar artery, So the vertebrals join together to form the one basilar artery, right? Again, here in the basilar, guys, I haven't drawn. There are what we call the perforator branches, I will show you all in a second. Just give me, we'll go to the 3D image in a second, right? We'll talk about those later. They supply the brainstem mainly, right? The pons region, right? We'll talk about that later, right? Then look at this. So we'll follow the internal carotid a little bit more. The internal carotid keeps coming like this, right? And here, guys, the internal carotid artery gives one large branch, right? This guy is large. We call him the middle cerebral artery, MCA, right? Okay. And then again, from the internal carotid itself, we get another branch going here more forward, right? We'll talk about what forward means in this diagram, right? The anterior cerebral artery, ACA. Okay. Right? Then, guys, if you take a look at here, remember our basilar artery, which was formed by joining of the two vertebral arteries? That one again splits. It splits into two. These two, right? We call it the posterior cerebral artery, PCA, right? PCA. These are the three major vessels that are responsible for our strokes: the middle cerebral, the anterior cerebral, and the posterior cerebral, right? Then, guys, right? Now, if I draw like this, right? The internal carotid, this was the basilar. Okay, let me take a different color, different thickness. Yeah, there we go. Right? This was the basilar artery splitting into the two posterior cerebral arteries, right? And then we had the internal carotid, right? Coming and giving the MCA and the ACA, right? ACA. This was our structure, right? Something like this. Now, if you all can see, guys, I will highlight these two in yellow. There are two other arteries that are connecting these together, right? Look at these, the ones in yellow, right? These are what we call communicating branches, right? So in the anterior side, we have what we call the anterior communicating branch, right? And here in the back, these two, both of these, we call them the posterior communicating branch, okay? Posterior communicating branches, right? So these two, the anterior and the posterior communicating branch, they help connect the internal carotid and the vertebral or the basilar systems together, right? this connection allows it to form this circular-like structure, which we call the circle of Willis, right? The circle of Willis. Now, you all are all clear about this brain's blood supply, right? No problem, right? Understood everything, 100%, right? No. Okay. No. This is, guys, this 2D diagram will stay in your mind. I don't expect you all to even grasp anything here, right? We will go to the 3D structure. This diagram before your exam, go through it and go for the exam, get through the exam. That is our education system, right? We cannot change it much until we get to some higher positions, right? So this diagram, it's good to just understand what the names of the branches are, right? Let me take you all here, guys. Let's come here. Can you all see this? Right? Okay. Right? I have put some of the screenshots of this for you all, right? You all can see the diagram, right? All clear? Huh? Right. Now, if we come here, guys, right? Look at this. First thing I want you all to realize, if we start here at the aorta itself, what did I first mention? The internal carotids are more anterior, right? You all can see these are more anterior, right? The internal carotids are the common carotids and then the internal carotids, these are anteriorly going, right? Whereas the vertebrobasilar, right? We talked about the vertebral arteries, right? These are more posterior, right? These are more posterior if you look at the side view. Okay. Right. So therefore, guys, now what are the branches the main branches that we talked about of the internal carotid, right? We said the anterior, ACA, anterior cerebral artery and the middle cerebral artery, right? Therefore, guys, these three, internal carotid artery, anterior cerebral artery and the middle cerebral artery, we call them the anterior circulation. Okay. Anterior circulation, right? Whereas if you look at the vertebrobasilar system, the vertebral artery, right? And the basilar artery right here. And then the resulting, we have here the posterior cerebral artery, PCA. These arteries are what we call the posterior circulation of the brain. Okay. So anterior circulation and posterior circulation. Okay. Now if I remove a layer of the brain, right? Let's remove one half of the brain, right? To make it more clear. Look at this, guys. If we look at this, right? Okay. So this was the basilar, right? You can see basilar, right? And the basilar gives rise to what we call this posterior cerebral artery. Not very important. We are not going to pay much attention to the posterior cerebral. But what I want you all to realize is the structure of this, the 3D structure of this anterior cerebral and middle cerebral. Look at this, guys. This is the middle cerebral, right? Middle cerebral artery. So the middle cerebral artery, you all can see, it is going to the side of the head, right? If you are taking in me, it's going like this, along the side of the brain, along the side of the brain, right? If you are take here, you all can see it's along this, right? This is the middle cerebral artery, okay? Right? It's going along the side of the brain. Whereas the anterior cerebral artery is going right in the middle, guys, right in the middle, right there. That is our anterior cerebral segment, right? Okay. So I have put a picture for you all right here, right? These ones, these are the same, from the same one, guys, the screenshots, right? What I want you all to understand, right here, this is the middle cerebral artery going along the side of the brain, going along the side of the brain. Whereas the anterior cerebral artery is going around the middle. If you take the two hemispheres, we are going in the middle of the two hemispheres, right? If I take a side view, this one, see this, what I'm drawing now is the anterior cerebral artery. Okay. Anterior cerebral artery giving all these branches, right? Whereas this one, which is going along the side of the brain, that is the middle cerebral artery. Okay. Is this clear, guys? I want to make sure this is clear for you all, right? Okay. Why do I want to make sure this is clear for you? Right? This is our next part, right? Look at this. If I draw, you all remember our homunculus, right? You all remember our homunculus structure, right? If I draw something like this, now this was our homunculus, right? Okay, motor and sensory both. This was just a cross section, guys. If I just extend this a little bit more, right? Like a piece of bread, imagine like a piece of bread, something like this. Right? If I just extend this same diagram a little bit more, right? Something like this, right? Okay. This entire zone that I'm going to color, guys, first starting from here, right? Starting from here and going like this, coming all the way this middle part. All of this is what artery? All of this. This is the anterior cerebral artery. Going right down from the middle between the two hemispheres, right? And supplying this medial portion of our entire brain, right? Medial portion, right? This is the anterior cerebral artery. Whereas if you look at this from here, right? Somewhere up to here, this portion, the more lateral portion, right? All of this is middle cerebral artery. Middle cerebral artery. All of this, right? All of this is middle cerebral artery. Okay. Agreed. Agreed. Right? And then here down below is the posterior cerebral artery. We're not going to talk much about this guy, right? Not very important. This is the posterior cerebral artery, right? Okay. Right? This is the diagram I want you to remember. Okay. That circle of Willis, all of that, just 2 days before the exam, take it and go, right? On the exam, sometimes some surgeons, especially, they will like to ask you to draw it, right? Especially in the Viva exams, they might ask you to draw it, right? Just draw it and show them. But that's it. Okay. This is what I want you all to understand. Where are they supplied, right? Now you all understand why that homunculus was the way it is, right? So when we talk about, okay, patient coming in with a leg problem. So the leg was where? Somewhere here. This was the leg, right? This was the leg. So this patient is saying, okay, I can't move my leg. That is, all this area is by whom? Anterior cerebral artery. So when the patient comes and tells you, I can't move my leg, or I have some sensory problem, I can't feel the pain sensation on my, around my knee joint, you all must think, anterior cerebral, right? Anterior cerebral territory. Okay. If the patient comes and tells you, doctor, my face is drooping, right? My face is drooping. What is that? Middle cerebral territory. Middle cerebral territory. Okay. Understood. Now, in your Vivas, guys, it's a bit of an act, no? Right? So even for my medicine Viva, what I got was a stroke case. One was a stroke case, and then I got a mitral regurgitation also, MR case. In my stroke case, right, what you all have to do, guys, in your exams is to get the examiner to ask more questions from you. That way, you seem smarter. Okay? You seem smarter. So you try to get the examiner to ask more questions. So when the examiner asks me, okay, I have this patient, 53-year-old, I think, coming with facial drooping and right-sided body weakness. So I know this is a left-sided stroke, right? And his upper limbs are very prominent. I will talk about that in a while. So I know where the stroke is, right? But what do I say first? What do I say first? Sir, when they ask, what is your diagnosis? So I say, sir, I think this is most likely a anterior circulation problem. And they ask, anterior circulation. What specific area, right? Now they're trying to stump me, but I already know what it is, right? But I'm taking the answer step by step, right? So then I will say, sir, because of these features, I think it is most likely in the middle cerebral artery territory, right? It's just to sound a little more fancy, but you can do all of that if you understand this basic, right? You can do all of that if you understand this basic. Okay, got it? Clear? Right. Give me a thumbs up. Right. Okay, excellent. Good. Now, one more important thing, guys, regarding the same thing. If I take, now this was a cross section and a little bit of an extended view. If I look at the same diagram from the top down, I'm looking at the brain from the top down. It will look something like this now, guys. Something like this. And there will be the central sulcus somewhere here. And we'll have the same zones being supplied. So for example, what did we say? Medial zones are being supplied by the anterior cerebral artery, right? The medial zones by the anterior cerebral artery. Then in black, we drew the middle cerebral artery. So middle cerebral artery supplies to all these lateral zones, right? This is middle cerebral artery. This is, I'm looking at the brain from top down, from top down. Okay. And what did we say here? Posterior cerebral artery will give to a little bit of this posterior portion and a little bit here also, right? Not very important, right? This is posterior cerebral artery. Now, what do I want you all to understand here, guys? When we have, right, a patient coming in, right? If he says, my lower limbs, right? Now he says, okay, let's start off like this. The patient comes, he says, doctor, my right side entire body feels weak, right? Okay, now you have to ask more questions, right? So you will ask him, okay, first tell me where exactly, right? Then he will say, doctor, entire right side, right? And then you have to say, okay, can you specifically tell me, is it your upper limbs or your lower limbs more, right? He's saying it's weak, right? Later in the examination, you can do specific examinations to find out. But in your history taking, you have to try to isolate the location. So you ask, is your upper limb weak more or your lower limb weak more, right? If he says his lower limb weakness is more than the upper limb, right? His lower limb weakness is more than the upper limb. Which territory do you think is more affected by the stroke? Which territory? ACA territory, anterior cerebral artery territory. Why? This entire red was lower limbs, right? Lower limbs, our knees, our feet, our legs, right? That is the one. This is upper limb plus or minus face, plus or minus face. Also, you can ask him. His lower limbs are affected more than the upper limb. You can put plus or minus face. Then same way, if another patient is coming and telling you his upper limb is affected more than the lower limb, plus or minus the face, what is our diagnosis? Where is the territory? MCA territory. MCA territory stroke, right? MCA territory stroke, right? Okay. This is based on the circulation that we just discussed, right? Okay. Then guys, okay. So now what do we know? Now we know based on the presentation. We know where probably the lesion is, where probably the stroke is, and we know which artery is likely involved, right? We know which artery is likely involved. For majority of our cases, guys, right? For majority of our cases, this much is enough to diagnose. This much is enough to diagnose. We have some other features to discuss. We'll talk about those also. But before we go to those features, those are some advanced stuff. Before we go to those stuff, we'll talk about what probably, now this is a ACA problem. This is a MCA problem, territory, right? The anterior cerebral artery. So we'll talk about now what probably caused this problem in the artery, right? So now we are going back. This is why, guys, so in universities, how they teach you is what? Causes, right? Etiology, risk factors, and then they go to the clinical features. I absolutely disagree with that method, right? We have to, the patient is the guy coming to us. So we started off with the patient. We started off with the clinical features. We looked at how those clinical features were manifesting. Now we located the problem in the brain. Now we'll think of what probably caused it. Okay. So now we'll go to the causes, guys. I have put the causes on your note, right? So let's take a look at that. Look at this, guys. Firstly, if we are talking about the etiopathogenesis of stroke, etiopathogenesis, right? Look at this etiopathogenesis, guys. There are two things, right? One is the risk factors we need to talk about. One is the pathophysiology or the causes, pathophysiology, right? If we look at the risk factors, these are the same as the ones for your ischemic heart disease, the same things we discussed last week, right? So what are the risk factors there? We talked about certain modifiable risk factors, right? We talked about fixed risk factors, right? What are the fixed ones? Age, right? Sex, these kind of things. Modifiable is what, guys? Our smoking, our alcohol consumption, right? Then what we call metabolic syndrome, right? Including what? Hypertension, dyslipidemia, diabetes, right? We have discussed all of these, right? Then there is, guys, another risk factor. We'll talk about that in the mechanism as well. What we call peripheral vascular disease. There is something called DVT, deep vein thrombosis, right? We'll talk about this in a little bit, right? We are going to go into depth for those, right? Apart from that, you know, your usual lack of exercise, right? Eating unhealthy foods, these kind of things, and also stress, mental stress, right? These are all these risk factors, right? So you all can write these down later, right? These are just things that you should know, right? Then, guys, if we come to the causes, right? If we come to the mechanisms and the causes, look at this, guys. Now, what is this? What is this stroke? Last week, we studied ischemic heart disease. What is stroke? Ischemic brain disease, right? Ischemic brain disease, nothing else, right? Same stuff, right? Different organ, right? So if we are looking at ischemia, guys, ischemia. Last week, what did we say? Ischemia involves what? Anyone who came to the last class, what did we mean by the word ischemia? We had three entities, if you all remember. One is the reduced blood flow. Blood flow reduced, right? Blood flow is reduced. That is one entity. Then we have oxygen, hypoxia, right? Oxygen is going to be reduced, right? Oxygen is going to be reduced. Then the other thing is, guys, removal of waste products. Removal of waste product, because you all know if blood is not flowing, you all know the capillary network, right? If blood is not flowing this way, there will be no removal of the waste products from the relevant tissues, right? So waste product washout is also reduced, right? We talked about the same thing last week. Now, look at this. If these three things are happening when there is an ischemia, let's look at how these things are brought about. One thing, guys, I want you all to write down the word global hypoperfusion. Hypoperfusion. What is this global hypoperfusion, guys? Global means when we are considering neurology, global, we say generally for the entire brain, right? This is global, right? What is this global hypoperfusion, guys? Usually what we are saying is not enough blood is being supplied to the entire brain. What can cause this? What can cause this? One thing is, guys, who is the guy who is pumping out our blood? Our heart. So cardiac arrest, right? Cardiac arrest, right? Cardiac arrest can cause global hypoperfusion, right? And another one, severe heart failure. Severe heart failure. Fourth, fifth interns, severe heart failure. How do we say it in medical terms? Now, according to the latest guidelines, it's not actually very late. It's been there for quite a while. Have you all heard of heart failure with reduced ejection fraction? Right? Heart failure with reduced REF, right? Reduced ejection fraction. Usually we say if it is less than 40%, guys, right? That is very dangerous, right? Okay. Anyway, right? We'll talk about that later in heart failure class. Okay. Right. One of my favorite chapters, right? Okay. So end of this program, we are having Dr. Umesh come in. He was actually a very good friend of mine, one of our batchmates. He's now working in the US as a resident physician, right? So he'll be coming in to do a session on heart failure. Okay. So you all can notice the differences, especially in the guidelines, guys, because he's in the US. Now the guidelines they use, they are a little bit different to what we use, right? But it's very interesting. So you all join that session on 15th, right? Okay. Come back here, right? So cardiac arrest and severe heart failure, right? That's one thing. So what is happening here, guys? When there is cardiac arrest or severe heart failure, the blood flow is reduced, obviously. And what is going to happen because of that? We have what you call the mean arterial pressure reduction. You all know in a blood vessel, when blood is flowing, there is a certain amount of pressure, and that pressure is required, right, in the capillary system to push out all the nutrients so that the cells here will receive it, right? So when this mean arterial pressure starts dropping, this doesn't happen, right? Tissue fluid formation also will reduce, right? When this doesn't happen, there is going to be ischemia. Okay. So when what is mean arterial pressure? Anyone? Seniors? How do you define mean arterial pressure? Huh? How do you define mean arterial pressure, guys? Anyone? Unmute. Quickly. Arinder? Let's go. No? Okay. Diastolic blood pressure plus 1/3 of pulse pressure. Okay. Right? Okay. No problem. Right? Juniors, it's okay. Seniors, I'm judging you all. Huh? Okay. No judgment here. Okay. Right? Okay. Mean arterial pressure. Right? Yeah. Okay. I asked the definition. Huh? Right. Okay. Now, mean arterial pressure reduced. Therefore, what is happening? Cerebral perfusion drops. Therefore, ischemia. And if the ischemia continues, infarction. Right? Then, guys, another one that can cause this global hypoperfusion is respiratory failure. How do you all think respiratory failure causes this? Again, when there is respiratory failure, we are getting one of these three entities. Which entity? Hypoxia, right? So when we get hypoxia, then tissue perfusion reduces, oxygen to the brain tissue reduces. Again, ischemia and infarction. Remember what we said. Stroke is always having an infarction. Stroke always has cell death. Whereas transient ischemic attacks, no infarction, no cell death. Okay. Our topic is stroke, right? Okay. So that is about global hypoperfusion, guys. Then the next cause, what we need to think about are any obstructive causes to the specific vasculature, right? So this is again, if you all joined the last week's class in ischemic heart disease, we talked about atherosclerosis, right? Same stuff, guys, right? Atherosclerotic plaques, guys. We are not going to go into depth in the ischemic heart disease. We went into super depth of how this atherosclerotic plaque is formed, how it ruptures, right? How the thrombus forms. We talked about all of that. You all can check the video. It's on the YouTube channel. Just if you all don't know how to get to that, just message one of the admins. They'll send you all the Notion platform, right? You all can go to the Notion platform and access the videos. They're all there free of charge, right? Right. So atherosclerosis, right? So obstructive cause giving rise to atherosclerotic plaques, right? Right. We talked about fissuring rupture, all of that, and that will give rise to a thrombus that causes blockage of the vessel, right? This atherosclerotic plaque plus a thrombus blocks the vessel. Therefore, the blood flow is cut off, right? Okay, giving rise to ischemia and infarction, right? Another one, guys. Another one I want you all to know. So that is atherosclerotic. Another one. These are what you call as these atherosclerotic plaques. We can classify it under a larger topic called thrombotic phenomenon. Right? Thrombotic phenomenon. Another one is called embolic phenomenon. Now, this is one of the most important ones when it comes to stroke, right? What are these embolic phenomena? What is an embolus? What is an embolus? Come on. It's okay. Huh? There are no wrong answers here. You all can tell me anything. Right? Come on. What is an embolus?
Dislodged thrombus.
Excellent. Nice. Arinda, very good. Huh? Also, so proud of your achievements, by the way. Excellent. Right? Keep going. Right? Look at this. Right? Dislodged thrombus. Right? What is happening here is, guys, when you have a large clot, right? What is going to happen, guys, if it breaks off, right? That one can come to a smaller end artery. Now here, it wasn't obstructing 100%, but that clot can move to a smaller end artery and obstruct that one 100%. Okay. That one will be obstructed 100%, right? So an embolus is a dislodged thrombus that goes to an end artery, most of the time an end artery, and obstructs it completely, right? Giving rise to ischemia of the relevant region, right? Ischemia, right? So here, guys, there are specific embolic phenomena that we need to talk about. right? One is cardiac emboli. Cardiac emboli. Now tell me this. How or what is a cardiac embolus? Right? What is a cardiac embolus? Any idea? Look at this, guys. I will go through this, right? If I draw the heart, right? This is the left heart, right? Here we have the right heart, left atrium, left ventricle, right atrium, right ventricle, right? You all know here we have some valves, right? So there is a specific condition called, we talk about these in valvular heart disease, different chapter, right? But for now, just know there is a condition called mitral stenosis. Whenever there is a stenosis, what does it mean? This valve is not opening properly, right? Whenever the mitral valve is not opening properly, guys, what happens? Blood starts building up here. Now, have you all heard of something called the Virchow stride? What is the Virchow stride, guys? Virchow stride? Virchow stride, Virchow's. So we have stasis, relative stasis of blood. What does stasis mean? Blood is not flowing. Blood is not flowing, right? Stasis of blood. We have hypercoagulability, right? Hypercoagulability, right? And vascular endothelial injury. This is the Virchow stride. Whenever one or more of these are happening in your vasculature, right? The chance to form clots increases, right? The chance to form, we call it thrombogenicity. Thrombogenicity increases. So the same thing happens here. Now look at this mitral stenosis. So blood is relatively being stasis here. So what is going to happen? Thrombogenicity in this area increases, right? So what is happening? There can be a clot formed, guys. This clot can dislodge, right? And go to the brain. Here we talked about the main three branches of the aorta and how from the carotids they can go up, right? We've talked about that. So that is one. Cardiac emboli, mainly write down mitral stenosis. Seniors, if there is mitral stenosis, any other manifestations you are looking for in the patient? Anything with ECG, anything with pulse? Right.
Yeah.
Excellent. Atrial fibrillation, right? We'll talk about that later, right? You are looking for a what pulse? Arinder?
Irregular.
Excellent, right? Excellent. Irregular pulse, right? Don't worry, juniors. Another topic, different topic. Okay, right. Mitral stenosis. Another thing is, guys, another thing regarding the valves again, the second one, mechanical heart valves. Write down mechanical heart valves. Mechanical heart valves, guys, you all know if there is a failure of a valve, we can use prosthetic valves, right? So there are bioprostheses and there are metallic valves as well, right? So whatever it is that we use, right? These are, guys, always foreign objects, no? Right? These mechanical heart valves are foreign. They're foreign, right? So whatever we use, guys, there is always a little bit of inflammation going on, right? Macrophages will be attracted because these are foreign equipment being put into your heart, right? So the thrombogenicity anyway, due to the inflammation, is higher with mechanical heart valves. So again, and another thing, with mechanical heart valves, there is a higher risk of something we call infective endocarditis, right? There are pathogens that can come and deposit in the heart valves, giving rise to something called infective endocarditis. Right? Different topics, we'll talk about those later, but for now, just know mechanical heart valves, right? Then the third one is infective endocarditis. That is the third one, right? Infective endocarditis. Infective endocarditis, just like what I said, guys, right? Pathogens from various sources, they can come and they can deposit in this endocardium, right? And they form what we call vegetation. We call them vegetations, right? Vegetations. They can form these vegetations, and these vegetations also can dislodge and go and block different areas, right? We call this friable, right? Okay. Now, look at this case. I drew a vegetation in the right heart. Okay. I drew a vegetation in the right heart. If this dislodges and goes, where will it go to?
Lung.
It will go to the lung, right? The right heart pumps blood to the lung. Excellent. Now I'm telling you, okay, now I'm asking you all, can this vegetation, right? Can it dislodge and go and cause a stroke? The right-sided one. If so, how? What do you all think first? Can it or can it not? Can it cause a stroke? Just guess. It's okay. No wrong answers here. Huh?
Usually the pulmonary circulation filters it, right?
Right. Excellent. Okay. Right. So it will go to the lungs. Okay. I agree. Can it go to the brain and cause a stroke by any mechanism? What do you all think?
If there's a connection between the right and the left heart.
Excellent. This is the problem, guys. If we have a defect here, you all know something called the atrial septal defect, right? An atrial septal defect. right? If there is an atrial septal defect, this guy can come and go to the left heart circulation, right? This is what we call a paradoxical embolus. Okay, paradoxical embolus. Why do we say paradoxical? It originated in one side of the circulation, here the venous side of the circulation, and it entered the arterial system via a defect in the heart, and it goes to the brain and embolizes, right? Okay, good, excellent, right? The paradoxical thrombus, huh? Right. Then, apart from this, right, what else do you think in the heart can cause? One thing is, guys, our common one, MIs, myocardial infarction, because you all know whenever there is an infarction, there is cardiac myocyte death. There is myocyte death, right? There is necrosis going on here. There is inflammation and necrosis going on here. Then there is inflammation and necrosis. Again, thrombogenicity, this hypercoagulability and endothelial injury, right? Endothelial injury is happening here. So thrombus formation can happen, and that can go and embolize. Right? Specifically, guys, this is common with anterior septal infarctions, right? Usually V1 to around V4 in the ECG, right? Okay, right. Right. Then again, what else? Yeah, these are the basic things I want you all to understand, right? So that is about the obstructive causes. We talked about thrombotic and embolic phenomena, right? These are going and obstructing the cerebral vasculature. The next thing I want you all to know is, guys, right? What is the next thing? Write this down, guys. There is something called internal carotid artery stenosis. Internal carotid artery stenosis, right? What is this internal carotid artery? This also, guys, in some books you all might find it called critical ICA stenosis, right? Critical ICA stenosis. What is this, guys? This happens when there is a drastic drop in the blood pressure, right? Drop in the blood pressure. Okay. What happens, guys? Now you all know, right? When we have a vessel, right? Okay. For it to perfuse, let's say here there is a group of cells, right? For it to perfuse these cells, the blood should come at a particular rate and a particular pressure, right? Everyone agrees. Blood has to come at a particular pressure for proper perfusion of this tissue, right? Now what happens if I tell you in this same vessel, due to some cause, the blood pressure drops? What is going to happen to the blood? The pressure is going to reduce. So the perfusion will drop a little bit, right? But what is our body's initial mechanism of compensation whenever pressure drops? Think about your garden hose, right? If the water pressure in your garden hose is low, what do you try to do at the end of the hose, the mouth of the hose? You try to tighten it a little, right? You put a thumb or a finger or something and you try to tighten it a little. And then when you do that, right, the pressure will come back on. Right? Just at the nozzle end, right? So that our body does a similar thing, guys. What does our body do? Our body slightly vasoconstricts the vessels whenever blood pressure drops to try and maintain that same blood pressure. Okay. But when there is vasoconstriction, what happens to the blood volume that is flowing? Volume drops, right? So even though there is a vasoconstriction, the volume is dropping. So this is what happens in this critical internal carotid artery stenosis, guys. Let's say you put the patient on some antihypertensives. You didn't check the patient's dosing or whatever properly, or the nurse came and you gave the antihypertensive dose now, you went home, then the nurse came and gave the next one without consulting anyone, right? What is going to happen, guys? Blood pressure is going to suddenly severely drop, right? Therefore, what is happening? The vasoconstriction becomes so much, right? There is a stenosis of the carotid arteries that is causing a drop in the blood volume that is going to the brain. Okay. So this is what we call critical. This is usually iatrogenic, guys. Most common cause is iatrogenic, right? Using antihypertensives at the wrong doses, right? But there also can be sometimes in septic or cardiogenic shock. Also, this can be seen, or septic shock, right? Septic shock also sometimes this can be seen. Okay. Right. Then, guys, apart from this, right, there are some other not very important causes, right? You all can write down as I say, right? One is vasculitis, right? There are certain vasculitic conditions, the inflammation of the blood vessels, right? Like you all might have heard something called Takayasu arteritis, right? These kind of not very common. These are quite rare, okay? And then you have infective etiologies, right? Varicella zoster virus, syphilis. You all might have heard something called syphilitic iotitis, right? Inflammation of these vessels. All of these can happen due to these pathogenic species, right? Then another very important one. Now, this is important. Last week, we talked about ischemic heart disease. What was one of our main diagnostic modalities? We used what you call an angiogram, right? We used an angiogram, right? We send a fine wire, right? when you all are sending this catheter, this fine wire through the vessels, what can happen, guys? Specifically the smaller vessels, there can be endothelial injury, right? This is quite a common phenomenon, guys, right? Iatrogenic, right? Specifically in small vessels, right? We can get dissections and clots, right? Due to this catheter-based approaches, fine wire-based approaches. Okay. Then the last one, guys, I want you all to also write down hypercoagulable states. What are these hypercoagulable states, guys? One thing, write down, right? And the CDS get ready. Protein C or S deficiency. Write down and I will explain. Protein C or S deficiency. Another one is antithrombin 3. Antithrombin 3 deficiency. Right? What are these? These are all protein C and protein S. These are glycoproteins, right? Produced by the liver. What do protein C and protein S do in our body? Seniors, juniors, it's okay. Even if you all don't understand this part, it's okay. I'm happy with what you all have done up to now. You all have time. Seniors, 4th, 5th years. Protein C, protein S. What do they do? What do they do? Come on.
Inhibit thrombin formation.
Excellent. They prevent blood clot formation, right? That is antithrombin 3 will go and lyse clots, right? Antithrombin 3 will go and lyse the clots, right? Whereas protein C and protein S, they prevent the clot formation, right? We'll talk about the mechanisms in hematology, right? Not very important today. Now, what is one nephrology condition that I have taught you all, the previous students, that causes protein C, protein S deficiency and antithrombin 3 deficiency?
Nephrotic.
Excellent. Nephrotic syndrome, right? Nephrotic syndrome. Okay. Right. So this is another hypercoagulable state that can give rise to strokes, right? Okay. So when you have a patient with nephrotic syndrome, what should you look at? Their clotting profile. You have to look at their clotting profile. Very important. Okay. Right. Okay. Then guys, another hypercoagulable state. Have you all heard something called polycythemia? Right? Polycythemia rubra vera, right? This is excessive production of RBCs, right? Excessive production of RBCs. Again, when there are too much of red blood cells being produced, what can happen? A relative hypercoagulable state. Okay. Then apart from this, guys, one more, drug use, right? Cocaine, amphetamines, these kinds of drugs also can cause strokes. Okay. Right. So now guys, now we know when a patient comes to us with some sort of weakness, we know, right? Based on where his weakness or sensory loss is, we know to identify which part of the brain is probably affected. Based on that, we know which vessel is most likely affected, right? And now we know what probably caused the problem in that vessel to give rise to those manifestations, right? That is it for today's class, guys. Tomorrow, right, we will take this a step further, right? Tomorrow we will talk about some other supporting clinical features, right? Right? Some syndromes, what we call the ACA syndrome, MCA syndrome, a little bit of advanced stuff. But if you all understood today's content, even if you're a first year, if you all understood today's content, tomorrow's content will be nothing, right? Okay. So tomorrow we'll meet at the same time. I hope everyone understood. Is today's lesson clear for you all, guys? Just give me a thumbs up. I just want to make sure. Okay. Right. I know your brain. Yes. Add you to the WhatsApp group, guys. Just message one of the, admins, who is this? Taimur, how did you come to know about the program?
I came to know about online. I applied online and they just mailed me.
Right. Okay. So what I'll do, I'll drop you an email, right? Can you drop your email address to me in the chat box here? Right?
Yeah,
I'll drop you
sure.
Yeah? Okay. Right.
I don't know any admin.
Right. Okay. Right. Right. So guys, is today's session clear? Just give me a thumbs up, right? I want to see your faces, right? Good. Excellent. Atib Ahmed. Understood? Right? Where are you from?
I'm at Dali Medical University, China.
Yeah. Right. Which year?
Final year.
Final year. Right. Okay. So you know majority of this, right? But did you learn something new today? That's my goal. Anything new that you haven't heard of?
Yes.
Excellent. Right. So I hope you all got today's lesson, guys. Just drop me a message, give me some feedback, right? Is there something I can improve, right? Because now I'm teaching again after like 1.5, 2 years, right? Forgotten the teaching style a little bit, right? But right, just drop me a message, give me some feedback, let me know if there's anything I can improve speed-wise, right? Clarity-wise, whatever, right? Just drop me a message, give me some feedback. I will meet you guys tomorrow, 4:30, right? You all can use the same link in the Zoom email. Huh? Right. Okay, guys, that's it for tonight. Right. Good night. Take care. See you guys tomorrow.